that pretest probability is such a crucial point, you know, and in particular, in addition to those that Serge raised, which I think are excellent, you know, what is it that raises the suspicion? You know, because it can overlap with a normal hemoglobin, but all those other things are factors. Other ones we clearly have found that really should really raise the suspicion amongst the treating physician is really that unexpected area of thrombosis. So one, it's not only thrombosis, but particular areas of thrombosis. You know, portal vein thrombosis is a biggie, certainly thrombosis in the skull, other areas, Budd-Chiari, and you know, why biologically these areas more than others? There's certainly interesting research looking into those reasons, but there's undoubtedly an important scientific clue, you know, why those areas of circulation. It can't be anywhere. It can be arterial, it can be an MI, it can be a stroke, but some of these other areas are really peculiar. Certainly in Budd-Chiari, certain series would suggest if you assess for the JAK2 mutation, you know, at least a third of them will be JAK2 mutated, and many of them without overt erythrocytosis. In fact, even sometimes their counts are a bit suppressed because of the acute reaction that they've had to the thrombotic event.
I think, but the rationale to change to lower the threshold is, again, that there were cases that were missed. We used to talk about this, you know, masked polycythemia, and in the setting of thrombosis and stuff, you could not call it before also having clonal markers. So I think the rationale for lowering that is really to allow making the proper diagnosis in those cases. I think in my experience, still, like as we say, common is common. So patients would still present with DVT and stuff and could have, you know, polycythemia. The other thing I would like to highlight is basically this is the only probably myeloproliferative disease that one could check for the exon 12 mutation of the JAK2, not just the V617F. It's probably not needed in any other disease, but there is a small subset. I am seeing a lot of patients challenging that everything looks like P Vera, but they are still negative for all the mutations. And then this day and age, how do you make that diagnosis? Is it true P Vera in absence of a mutation?
So that was going to be one of my next questions. When I go and lecture and talk about this disease, everyone has a patient or two that's been through the entire workup for erythrocytosis, including all of this that we talked about, and nothing is obvious. And the question is, well, how do you manage those patients? What I tell them to do is tell them to maintain, keep them well hydrated, put them on an aspirin. I typically don't recommend cytoreductive therapy there because you don't have a diagnosis of cancer.
See, I tend to think that if you have someone who, like, you're probably talking about that 1% that doesn't have clonal hematopoiesis, if you will, but I think you should see something on the bone marrow. And if there's nothing in the bone marrow biopsy that supports a myeloproliferative neoplasm, then I would like to try and find some other cause. I mean, oftentimes patients are taking testosterone, and if you don't ask, they won't tell you, or something over the counter that may cause a very similar effect. And so I suppose the real question is what happens if you have someone who's taking testosterone causing erythrocytosis, and what is their thrombotic risk? I'm not sure that we have enough data in the literature to support what we should be doing, but it's a problem.
The presence of the JAK2 mutation, either the V617F or exon 12, is not mandatory for diagnosis. That we have to recognize. And there is a link mutation that we know can happen in occasional patients, or there is possibility of, at least in Italy, they reported a couple cases of calreticulin positive PV. But nevertheless, one practical point here is that testing needs to be sensitive as is specific. And many times in community setting, the sensitivity of the tests for JAK2 V617F is not good enough. They come with 10% sensitivity, 20% sensitivity. I've seen it in consultations all the time. They say it's PV, everything is PV, but it's JAK2 negative. They may have a low JAK2 V617F allele burden. It doesn't have to be 50%, it can be 10. And the sensitivity is 20, you're not gonna catch it, it's false negative. So the proper test or proper sensitivity of the test is an issue sometimes to make a diagnosis.
Well, okay, but let me push back on that a little bit. The other side of the coin is you brought up clonal hematopoiesis, indeterminate prognosis. You have a patient with a hemoglobin that's running 17, and they're 65 years old, and you do a myeloid gene panel or just check for JAK2, and you do have a sensitive assay and it's positive. that doesn't mean that the patient necessarily has PV. They could be true, and unrelated. It could just be clonal hematopoiesis. So, and that's probably the reason why the allelic burden isn't actually included in the diagnostic criteria.
I think the JAK2 was one of the top 5 mutations you would see in the CHIP
Yes, in
patients.
CHIP.
In older people that don't have any disease.
Right.